All right, well, let's then open up the floor for just questions across all. I mean, I think it's been a really interesting mix of presentations that we've had today. It is a lot of information from three very different contexts, but you can see some similarity both in what happens with occupational health and how it rolls up and has the potential to roll up into the public health system, whether it be in Brazil or in Thailand. But you can see that there are spotty coverage issues in both circumstances, not enough resources to stretch beyond, and of course partnership concerns about how to be able to cover the needs of the informal sector when really trying to tie it together with public health. And then of course with what's happening with Chaz and in Zambia, really interesting model of one, how a new service may have been born in thinking about home-based care and really going beyond what the traditional health system was providing and moving deeper into the community based on what was truly needed by those in need, albeit for HIV, but clearly a model that could be expanded for more. And then also looking at the health infrastructure that the church does provide within a country and how that can help extend what the health system can provide within a local context. But again, spotty, not only because of coverage, but also because of the resources and the interdependency of what is required when you have that infrastructure and depending on what the government can provide. And I think across all of these examples, we see that the kind of the unstable foundation when you are that dependent on the public health system in the country as you're moving forward with a partnership based on resources, whether they be the health, human resources, or actual cash that could be made available. So with that, I've bought a lot of time in hoping that there'll be other questions that we can bring to the floor. And let's start with BT.
Sure, thank you. And what a fascinating set of panels today with a great spectrum of information from anywhere from policy to what private sector is doing in this area to actually on the grounds in terms of the developing world. So as a member of this forum, I'm very interested in the role of public-private partnerships in the context of universal health coverage. And throughout today, I was thinking about listening to the panelists of each session of where private sector can play a better role in the application and implementation of universal health coverage. And I think the key here is looking at, one is technology and innovation, how to apply that. Another is looking at how to collectively and systematically and cost effectively collect data and be able to analyze that going forward. And I was just wondering, looking at a potential business model in which let's say that country X in developing world wants to implement UHC, could they work with, for instance, a private sector insurance company to try to devise those plans and then work with a carrier such as SoftBank or Vodafone or something like that to actually collect the data and provide similar to kind of social security numbers to each person throughout the country, and so that they can, one, monitor the patient and monitor the population. They can gain taxes from that. They can regulate taxes from that individual. They can also provide health care to that individual or coverage and rather access. And then you have a circular in terms of a win-win for both private sector and public sector. And I'm wondering, given that I'm not an expert in universal health coverage nor of any of the discussions that occurred today, if such models have been discussed at either the country level, at the WHO level, or at the private sector level. Thank you.
Are there any examples or folks from the floor that can contribute? I'm sorry, I can't reach over to see. Yeah, there you go. Please begin.
I don't think this was developed with the government, but there is an insurance company called Bupa, and Airtel as the provider, and a microinsurance company called Micro Ensure with an E that has rolled this out in Ghana and reached really significant scale. And I think that exactly what you said is a really good example of how they're using the existing pipes of the network and the scale of an insurance provider and their actuaries to figure out good rates and data systems, and then an entrepreneurial strategy and boots on the ground to reach into these communities.
Is the payer for that the government?
I don't know.
Because I think that's the key here, is to tie government with private sector as opposed to just having a private sector model.
It's a really interesting model to be able to think through. One more input on that, and then we'll move to another question. Go ahead.
Just to respond to that as well, I recently spent some time studying the Indonesian system, which is currently rolling out universal health coverage and is poised to be actually the largest universal health coverage system in the world. And their approach is primarily a public payer system, but they're increasingly looking towards private insurance providers to bridge that gap, because I think, as we've heard throughout the day, financing is such a critical issue. And the government simply does not have the funds, even though, you know, it's constitutionally guaranteed that they're going to cover a broad range of services and universal health coverage is a priority for them. The funds simply aren't there. And so they're looking increasingly to other sectors in the private sector and private insurance specifically to bridge that gap. So what they're looking at is for private insurance providers to provide supplementary benefits, especially for, you know, increasingly expensive medical technologies, things like that. So there are, you know, ongoing discussions right now, but should be interesting to monitor.
Great, thank you. Before I move on to another question, just want to check with our panel. Are there any examples from the private insurance industry based on what you've been working on that can add to some of the questions that BT is asking?
I know for Zambia, we are discussing the insurance, but I think the challenging issues are that, you know, we have the majority of people living below the poverty line. And in the rural areas, how are we going to address that? I know the debate has been going on, and our country teams have gone to countries where we felt that maybe that was working well, like Ghana. And even when you hear from Ghanaians themselves, they will tell you that the system still has flaws. So there's still people who are still not receiving access, having access to healthcare. But in terms of informal, the people who are working in Zambia, and we're only, I mean, for a population of 14 million, we're only about 500,000 that are working formal employment. And Zambia is one of those countries that we are highly taxed. And so you are subsidizing others. But even then, we still have, one good example is the indicator of that can show that not everybody is receiving access to care. We still have more than 46% of our mothers still delivering at home. And not because they don't want to go to the clinic, but you know, when you improve the health systems, or if you decide to decentralize, you must make sure that all the sectors have decentralized. And so what has happened in Zambia for the longest time is that you didn't have the road network. So people, pregnant mothers in labor, go into the clinic, and they would have to travel 20 kilometers or 20 miles, 100 miles, and there's no way they're going to go there. And we have had cases, fertility cases, where a mother is trying to go to the clinic and they've bled to death and they can't make it. So you need to have the entire system working, not just the health sector. And sometimes that's where we make mistakes. We concentrate on the health sector. We need to have all these government departments, the road network and other things also working and moving at the same rate and decentralizing at the same rate. Otherwise, not just the health systems. So I think we're struggling with the health insurance in Zambia right now. But for those of us who are working, then you have some insurance that is, yeah, but you have to be in formal employment.
Great, thank you, Karen. Derek.
Yeah, thanks. You know, I've also been sitting thinking through one question that I think has been asked a few times, and that is, why should companies engage in the health of informal workers? And I don't have the answer, obviously, but I do think that maybe tomorrow we need to think about what are the most compelling cases that we can put together. And so some of the ones that I think we got out today there could be a start. The one is, and in no rank order, that you should certainly be investing in second and third tier suppliers. And we heard that from some people. And why should you do that? Obviously, there are many reasons. One, if you don't buy the argument, is that Oxfam and Bloomberg will come after you if you don't. And they've already been doing very strong exposés on second and third tier employer suppliers who may not be meeting the standard of the major multinational. That is a big push, and investors are now looking at that very seriously. The second is that many of these informal workers are your future employees. So that is a good rationale to make sure that your future employees are in the best health status that you can get them into. And on the insured issue, that's the logic we are going to be using in South Africa to use our insured base addressing tobacco cessation to expand the capability into the uninsured population with the Department of Health, really to argue that if the entire population's smoking rate goes down, our workers plus future workers all benefit. Otherwise, you're going to have pockets and people are going to go into it. And I think that argument we could probably become more sophisticated. The third one is that obviously for many companies, informal workers are your consumer base. And we presumably believe that the healthier they are, the wealthier they are. And investing in some aspects that are going to improve their stability. Things, for example, like better security and lighting have a big impact both for your own employee base, but also for your future consumer base. The fourth one, which I think has been shown by many Indian studies, is the power of reverse innovation. And that the best site of doing reverse innovation and the best groups are those where the price point is extremely low and where the opportunities for developing new products and services in the most cost-efficient way are best done with folk in the informal sector where this is a daily reality. And there's been some interesting examples of that. I think the Kenyan financing system is just one spectacular example of how that's starting to work. And finally, when all fails, there's the reputation issue. Many companies can be persuaded to invest in the health of their local community, or at least make sure they don't get engaged in making the health of their community worse. And that itself is, at least ensuring you do no harm, is at least a starting point for some of the action. And that relates particularly to big extractive companies or to tobacco companies or to unhealthy food companies and so on.
Great.
But I think if we could build on a hierarchy like that, I think it would help us make the case both within the corporate world, but also to see the bridge.
Well, and what's interesting, especially the interesting example from South Africa about smoking cessation, starting to use some of the best practice models that exist within some of the sector and taking it out will be interesting to see. Sure.
I would just add that informal workers are also part of your distribution chain, right? So if you want to get chewing gum out to the communities, they're doing it, the newspapers, the Coca-Colas and all of that. So they're not just on your production chain and your consumers, they're part of your distribution chain.
Very good point. So let me turn to Kathy, who's been patiently waiting, and then Yvonne for your next question as well.
Thanks. It was a great set of presentations. I really enjoyed that. My question might primarily go to Karen, but if others have a comment on it, I would appreciate that. You know, if we assume that this sort of mixed model of service providers makes for a stronger system, so that's including the Ministry of Health, government, private for-profit, and then private not-for-profit, which is the faith-based institutions. I see a lot of programs and projects that are focused primarily on the Ministry of Health. And even though the faith-based facilities are providing up to 50% of the health care. And can you share some thoughts with us on what can be done, should be done to keep those faith-based hospitals sustainable and operational in the face of sort of more inputs going into the government side?
Of course, government will always lobby that more input goes into government, and sometimes we have to give them their place. But I think for faith-based organization, as a case of CHAS, if you've been able to demonstrate that you're accountable for those resources, even the government is persuaded to directing some of the corporate partners to, why don't you go and see CHAS about this one? I mean, the case at hand was when we had some of our partners from abroad wanting to work with the government in telemedicine. And so the Minister of Health himself said, look, we are very bureaucratic, and we know that we want to do this, but we would want you to go to CHAS because they can do it faster, they can test it, and then we can see how it goes, and then we can scale it up and we can embrace it in government facilities. So I think one of the key issues, I think, is for faith-based organizations to be accountable, to demonstrate that they can do maybe not better, I don't like to say better, but they can just do as good as government. And government will always be government, because we have to give respect, they have to regulate, they have to provide all the guidelines. But I think in our region, in sub-Saharan Africa, from Kenya, even Sudan, the new Sudan, we provide 40 to 60% of total national health care. And so we are forced to reckon with. And I think that even our partners, cooperating partners, not just looking at government, but also saying who else is providing the total national health care, but also for the faith-based organization to work very closely with their government, because that's where the sustainability issue comes. For the case of CHAS, if we made sure that at independence that government was providing at least 75% of the resources. And because before independence, we had mother churches from America, from England, from Europe, supporting those churches. But as you know, over the last 40 years, that support is no longer there. Oh, it's very fragmented, it's very scarce. And so we depend on our local government. So we cannot, as faith-based organization, antagonize our government. Rather, we need to sit together. Not that CHAS always agrees with the government, but we have modalities where we sit together and say, this we don't agree. So I think even for our partners, I think in our region, if we're talking about universal access, it's the faith-based organization that are in rural areas. And in most cases, the faith-based hospitals are the only district hospitals, and sometimes they are referral. So you cannot afford to ignore that sector if you want to achieve universal coverage. You can't. Not in our region. You can't ignore the faith-based organization, because they're spread throughout their countries and delivering healthcare to the needy and most hard-to-reach areas.
Thank you. So I know we're tight on time, so Yvonne and then Marty will have to be quick at the last word.
Right, just
I'm sorry, of course.
to respond to the question about examples of the role of the corporate sector in universal health coverage. There's a good case study described in Tanzania by the German International Development Agency on one corporation that is dealing with cacao butter, and that corporation has committed and started providing funds to the local community health fund in a district to extend the coverage from the poor to cover also the informal workers in the district, because the company said this is very important for us. On another line, several years ago, we had a discussion with the U.S. Council for International Business and several multinational corporations about provision of health services in developing countries. And these were U.S.-based corporations that they were very committed, and not only committed, they had to provide the health services to workers and their families because the local health systems were very weak. But they were interested in some form of a public-private partnerships to coordinate this healthcare provision with the rest of the health system and to ensure the continuity of care.
Great examples. Marty, please.
Yeah, just 2 points. One is, with all due respect for the church-based organizations, I think we have to remember the faith-based, that there are non-faith-based NGOs that also produce and provide significant services on scale. And the second point, and I know this is touchy, but I do feel the need to raise it because it's always raised in the context of informal workers. It's on the taxation issue. The lead sector of growth in India, my country, is the IT sector. It has had a tax holiday since the beginning, extended to 2017. The biotech industry felt it didn't get such a good deal. And then we hear that the informal worker that Mirai talked about, who makes 1,000 kites in a day in her home sitting on the floor, earns $2, is not qualified for below the poverty line benefits. How much are we going to squeeze out of the vast majority of these informal workers who earn very, very little? And the other point about taxation is they actually pay them. They pay, it may not be the formal taxes, but operating fees, bribes, they pay a lot, and we're trying to document how much they pay. And then they feel that they're entitled to services that they're not getting. So I think the tax issue really has to be opened up to look at the whole system, because the formal firms, thank you very much, are also not paying taxes.
Please, Victor.
I thoroughly enjoyed the day, the time I've been able to spend here, and really there's a lot of great lessons, exchange of ideas and proposals. I think the issue is, as I hear it, we have a tendency to think about solutions as engineered, perhaps a little top-down, if you will. And many of those issues that we've talked about and bring people together to find solutions, I just want to bring back my earlier comment that there's a lot of innovations happening every day, and people who are close to the ground are finding those innovations. Admittedly, our example is on health delivery, not UXC, but I think Sarah just pointed out that Bupa is another example of, in fact, innovators who are finding solutions, right? So I think one of the conversations has to be, how do we help those innovators, and not just how do we engineer solutions for them? And, so the conversation will be a little broader in terms of the constituents, the components I said. But Derek is right. We have to make the compelling case for people to come together. But if we can do that, I think the solution is going to be a lot more grassroots than you believe. And those grassroots, particularly as you see, that we've seen in India, in Africa, et cetera, are things that we want to reverse innovate here in this country. And so we should be embracing those opportunities from a public-private partnership viewpoint. And importantly, the government has to come around and understand that those are solutions. They're not in the way. They're not competing with the system. And that businesses have to be there to provide them with that help to be able to build those possibilities. I just want to bring that back for consideration for tomorrow as well.
Thank you, and I think we're going to need to close with that, and please join me in thanking our panelists and this great, robust discussion we've all had.